Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcasts, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adewuya. Joining me today is Dr. Natalie Lui. Dr. Lui is a board-certified thoracic surgeon and assistant professor of thoracic surgery at Stanford School of Medicine. After earning her MD at Johns Hopkins School of Medicine, Dr. Lui completed a residency in general surgery at the University of California, San Francisco, where she became involved in thoracic oncology research and completed a Master of Advanced Studies in Clinical Research. She went on to hold a fellowship in thoracic surgery at Massachusetts General Hospital and continues to specialize in thoracic oncology. Dr. Lui's clinical focus spans thoracic surgery with special attention to lung cancers and the use of robotics in surgery. She additionally conducts research related to increasing rates of lung cancer screening using intraoperative molecular imaging for lung cancer localization and robotic surgery education. Dr. Lui, thank you so much for chatting with me today.
Thank you so much for having me here.
I am excited to talk to you about lung cancer, but specifically lung cancer screening. There's a lot we can cover about this topic, but I thought a really great place for us to start is at the high level. Can you provide a really high-level overview of lung cancer? Some of the underlying pathology that will set the stage for our conversation.
Lung cancer starts as tumors that grow in our lungs, which are the two main organs that sit in our chest and provide oxygen to us. And there are several different kinds. Sometimes people will refer to small cell lung cancer or non-small cell lung cancer. The most common type is a type of non-small cell lung cancer called adenocarcinoma. And lung cancer is the most common cause of cancer-related death in the United States, worldwide. It's not really that well known. So it is the second most common type of cancer in women after breast cancer, and the second most common type of cancer in men after prostate cancer. But it is much more deadly than either of those types of cancers, and it causes the most number of cancer deaths. Again, in the United States and worldwide.
I think that's important to note because we talk a lot about breast cancer in women, we talk about prostate cancer in men, but that statistic is the most common cause of cancer death.
That's right. In the US, about 20% of people who die from cancer die from lung cancer. So this is about expected 125,000 people in the US this year.
And I'm sure we'll dive into it a little bit more because the one thing that comes to mind for me is the equation of lung cancer with smoking. And given that number, it can't all be about smoking. And I don't want to jump ahead of myself. That's an important point of a conversation. But let's talk about lung cancer screening because that is such a huge number of cancer deaths. Lung cancer screening is so important. What does lung cancer screening typically involve, and why is early detection so critical in improving patient outcomes?
Someone could have a small tumor in their lung and feel completely normal. They could breathe normally, they could go about their day and exercise, and they have no idea. It's usually only when a lung cancer becomes a lot bigger or spreads that it would cause any symptoms. So, for example, if a tumor got so big that it was pressing on an airway, someone might start coughing or coughing up blood. If the tumor spread to the brain, someone might start having headaches. Or if it spread to the spine, someone might start having backaches or back pain. And so it's only at that point when people have symptoms that they would usually go to their doctor and get evaluated. And you can see these symptoms are all pretty common: cough, headache, back pain. So even when they go to their doctor, it might take a while to get the diagnosis of lung cancer. So in the US, most people who get diagnosed with lung cancer have advanced disease. We have a staging system, 1 through 4, and 1 is the earliest. 4 means that it has metastasized or spread to another organ. And most people are diagnosed in stage 3 or 4 because that's when they have the symptoms and go get evaluated. So screening means looking for people before they have symptoms. And now we currently screen using a low-dose computed tomography scan, or CT scan, or CAT scan is another name we have for it. So LDCT. And for heavy smokers in the US, we recommend an annual LDCT.
I think that the fact that the symptoms are things that you could attribute to a super active weekend, maybe you strained yourself and had back pain, probably adds to the challenge of early diagnosis. I'm curious about, how do you delineate between, oh, it's just really back pain, and oh yeah, I just have the common cold and cough. How do you handle that?
That's one of the hard parts about being a primary care physician. If someone comes in with a cough, they probably don't have lung cancer, but it is important to try to figure out what is causing the cough and treat it. And if it doesn't go away, then to become more aggressive in the evaluation. And so a lot of times people will end up getting a CT scan for a cough. This is a diagnostic CT scan because they're responding to symptoms, instead of the low-dose CT scan, which is what we recommend for screening, which is before someone has any symptoms.
Smoking, we all know, is a risk factor for lung cancer. How does screening benefit smokers? And what other groups should clinicians consider screening?
Smoking is definitely the primary risk factor for lung cancer. In the US, about 80% of people diagnosed with lung cancer have smoked at some point in their lives. And so the current guidelines for screening only recommend screening for heavy smokers. So there are 3 criteria: age 50 to 80 years old, a smoking history of at least 20 pack years, and either a current smoker or quit within 15 years. Now, a lot of people have asked me what a pack year is. We use this commonly in medicine to quantify what someone's smoking history has been. And so to estimate their exposure to cigarette smoking, we multiply the average number of packs per day that they've smoked by the number of years that they smoked. So one example of someone who would meet a 20 pack year threshold for screening would be someone who smoked an average of 1 pack per day for 20 years. And you multiply those and you get to 20. But there are a few different ways you can get to 20. So if someone is a really heavy smoker at 2 packs per day, they would only have to smoke for 10 years.
So it's helpful to understand that there is a specific criteria that clinicians should be aware of when considering screening for smokers. What other populations should be considered?
Right now, the U.S. Preventive Services Task Force, or USPSTF, those are the criteria that they use, and that is what is covered by Medicare and other insurance. But we do know that other people are at risk. There are other societies that have different guidelines. So, for example, the National Comprehensive Cancer Network, or NCCN, has a second group of risk factors that they consider, like exposure to secondhand smoke, exposure to occupational chemicals, radon, lung diseases like tuberculosis or COPD, a family history of lung cancer. Those are all part of their list of risk factors, but it's currently not covered in the United States. And then the American Cancer Society, as another example of how there is some disagreement about what the criteria should be, the American Cancer Society recently removed the quit date criteria from their recommendations. And so they only recommend the age of 50 to 80 and the pack years of 20. And they thought that it would be probably more equitable to get rid of that, and easier because it's just a lot for people to remember to figure out whether they're eligible or not.
I can see how multiple recommendations can be challenging, but then ultimately it's who's going to pay for the screening test. What are your thoughts on the idea of screening being recommended for all patients, regardless of their risk factors?
That is a really good question. So the low-dose CT scans do have risks. Besides the cost of doing the scan, there's radiation exposure. It's about the same amount as 6 months of natural background radiation, but it's not something that we want to do for someone with very low risk of lung cancer. Other risks include false positives, so finding a lung nodule that's initially worrisome that might prompt additional tests or even biopsies, sometimes even surgery to remove it, which end up being benign or negative. And so that's a lot that someone might go through. There's a lot of anxiety with the tests as well. And then there's also a risk that we would find things that are abnormal that wouldn't hurt somebody that we end up treating. And so because of these risks, we don't recommend lung cancer screening for everybody, but there is some thought that people outside of the current criteria could probably benefit, and we need to do some more research to figure out which groups those are.
It sounds like there's a potential to expand, but not expand to all, but more data is required.
That's right. If we screened everybody starting at a young age, we would find all lung cancers early, if that was somehow possible. But besides our healthcare system not being able to handle that much screening and testing, I think it probably wouldn't be a good idea for people who are really at low risk. It's hard because we do have outliers. We see people who are very young who wouldn't meet screening criteria, and we see them diagnosed with advanced lung cancer. And it's hard not to wonder who else, how could they have been screened? Who else should be screened to prevent these cases from happening?
Is there a higher risk around lung cancer when you talk about Black population, Latino, Asians, or is that an independent variable?
One of the biomedical informatics faculty here, Summer Han, as well as one of our former Stanford Thoracic Surgery fellows, who's now at Massachusetts General Hospital, Jeff Yang, both of them have done research on the screening criteria and how that affects disparities between African Americans and other racial populations in the US. And so, interestingly, they found that using the number of years smoked instead of the plaque years would decrease disparities. So they look at things like what percentage of people in different groups with lung cancer would have qualified for screening. And so when they use the current criteria, the proportion of African Americans who would qualify is much lower than the proportion of Caucasian Americans. So when they tried different screening criteria and used, for example, the number of years smoked instead of pack years, and found that actually a lot more of those African American people with lung cancer would have qualified in that way. As you can imagine, this research is pretty difficult because there's a set of research where it looks at people with cancer, and so you can see whether they would have met the screening criteria or not. But what's even better is if you have the entire denominator, the cohort of healthy people and the people who will develop lung cancer, and see how many people would you have to screen in order to find a certain number of people with lung cancer. And so Dr. Yang had looked at databases in the southern United States. Dr. Han has looked at databases in California and Hawaii. Of course, very different racial and ethnic makeups there. But they have found similar things, that changing the criteria from pack years to years of smoking might actually decrease the disparities a lot among different groups.
That's incredible. So what do we do with this information? What's the next step? Because it sounds like the guidelines need to change.
I know. I think it's really hard because it is hard to get this data, and none of this data addresses the mortality benefit in the way that this randomized trial of 50,000 people did. And that's not feasible to repeat that for every group that you are interested in. And so I'm very glad that medical informatics and statisticians like Dr. Han are looking at these databases to try to extract the information without doing a huge trial. And I do think that as we continue with these research avenues, that we may be able to change guidelines.
It's slow but necessary work.
Another group that's affected are Asians and Asian Americans. We talked about never smokers who develop lung cancer. In the US, about 20% of people diagnosed with lung cancer had never smoked. And in Asia and among groups of Asian Americans, it ranges all the way up to 80%. It's very different. It seems like a very different type of disease. And so because of that, there are many countries in Asia who are offering screening already, even to people who've never smoked. So these guidelines are very different than what we find in the US. And one of the most developed studies was in Taiwan called the Talent Study. And they enrolled people, men and women, who had never smoked, who had one other risk factor. So that could be secondhand smoke or family history. And they actually found that they detected lung cancer in 2.1% of that group, which is even higher than what was found in the heavy smokers in the National Lung Screening Trial. And again, about half of the people had stage 1. So this was definitely finding more early stage disease. And based on that study, they started the early detection program. So they're currently screening people with family history. So never smokers with family history, because they found that was really the biggest risk factor for the people who had never smoked.
That's a really great segue to my next question. You have a really great example of Taiwan and what we can learn from these approaches. I completely understand that the United States is unique. We are made up of a diverse population, and so it's not a one size fits all, which it's part of its beauty, but it's also challenging to address some of these health issues. Are there any other countries that have taken that similar approach that have been successful or not?
There are several countries in Asia who have been screening never smokers, but I think the largest one is in Taiwan. Easiest for us to look at their publication. It's been fascinating learning about screening around the world. There's a World Conference on Lung Cancer every year that the International Association for the Study of Lung Cancer puts on. And so they always have people from around the world giving talks about screening programs in their countries and what they're doing to implement them. And it's really a very wide range from countries who don't have any screening programs at all to ones that are just completely covered. And so I think the US, we know that we have a long way to go, and we have ways to learn from other places in terms of implementation and getting people who are eligible in for screening.
We talked about low-dose computed tomography, LDCT. Can you just give us a little bit more insight? How does it work, and what has made it sounds like the preferred method for lung cancer screening?
Computed tomography, or CT scans in general, are a mix of X-rays and then computer assistance. And so essentially it puts together a very detailed picture of the lungs and really the entire chest, where we can see really tiny lung nodules using these CT scans. And the technology has gotten really good so that the radiation exposure for LDCT has become quite low enough that we feel comfortable recommending an annual scan for people for screening. I will add, the low-dose CTs are really quick, so they just take a few minutes. They don't hurt at all. People just have to climb onto the bed, and then they get moved into the scanner, which is like a donut. And for the LDCTs, there's no needle involved, no IV, no contrast. So it really is quite quick and convenient for people.
What were you doing before LDCTs?
We were not doing any screening.
Oh,
yeah, there were a lot of people looking into chest x-rays, which is one single film rather than the LDCT, which is many films in a lot more detail. Some people looked into sputum samples, so looking to see if there were tumor cells in sputum that people would cough up. But it wasn't until the National Lung Screening Trial, which was performed in the US and published in 2011, that showed that there was a mortality benefit. So that trial, the NLST, was sponsored by the National Cancer Institute, and it was a multi-center trial across the US that enrolled over 50,000 people and randomized them to either the LDCT or the chest x-ray. These were all heavy smokers. And they found that the group that got the annual LDCT had a 20% lower death rate from cancer. 20%. And so that's really what sparked the change in the guidelines in the US. So that paper was published in the New England Journal of Medicine in 2011. The USPSTF recommended screening based on those criteria of the trial in 2013. And then Medicare started covering it in 2015. And since then, we've made some smaller changes in the eligibility criteria. There were some studies in Europe that showed that people with slightly lower smoking history might benefit. And so the USPSTF has revised their criteria a few years ago to take into account that new data.
Well, that's interesting. 2015 is not long ago.
Right. It's pretty new.
I am amazed by how innovative and advanced medicine and clinical care is, and how it can be in so many areas, but also how it is not in so many areas.
It's really fascinating to see this change over time, because I was essentially in training and a new surgeon when all of this was happening. And so to see it in real time and see how health policy then reflects the medical research has been really fascinating. And a lot of people ask why surgeons are involved with screening, because it's really seen as a primary care arena. And, I think surgeons really saw the impact that it made on patients, because I can operate on someone with stage 1 disease and potentially offer them a cure. By the time it gets to stage 4 and it's advanced, it's very rare that I can offer anything. And so we love seeing screening, and we're huge advocates for it, because we want more people to be diagnosed in that early stage when we can be helpful.
What an incredible outlook, too. You've talked about the recent changes in the screening guidelines. I want to pivot to some of the barriers that patients face when accessing lung cancer screening. What have you seen, especially in underserved populations?
That is a really great question, because despite lung cancer being covered for almost a decade now, our screening rates are really low. In California, it's estimated that only 16% of eligible people are getting screened. That's a lot of people that might benefit that are not getting their annual screens. We've looked into many of these barriers, and I think that it is really multifactorial. I do feel like a lot of people still don't know about it. It's been almost a decade, but it's still really new. We've done some surveys at community health fairs and found that the percentage of people that know about lung cancer screening is far below people who know about mammograms for breast cancer or colonoscopies for colon cancer. It is still just not widely known in the community. I think another part is that primary care physicians are usually this first access point to screening, and they have been really overwhelmed. It's hard to fit screening, which is by definition not urgent, into a short visit when you have many other medical problems to discuss. And so that's a big part of it. And I think making it much more part of the workflow for primary care physicians and assisting them and supporting them in that is really important. And then there are different factors in terms of the health policy, which may be larger and we can really change, but it's pretty confusing to know how much people will pay. It all depends on their insurance. Things are covered, but there are questions about co-pays depending on insurance. And I think a lot of that just reflects our healthcare system, and it's hard for us to answer some of those questions.
I think you're spot on there. I can see how all of those factors would impact. I'm curious if you've also seen whether socioeconomic factors, whether it has an impact to adhering to lung cancer screening guidelines. Because I think what I heard from you is that these are annual, right? So it's not just a one and done.
I don't know specifically about adherence, but there have been a lot of studies about disparities among groups, racial and ethnic groups, in terms of lung cancer screening. When you look back at the National Lung Screening Trial, which prompted all of this, over 90% of the participants were white. So about, I think, less than 5% were African American, about 2% were Asian. So it doesn't totally reflect the US makeup, and, even worldwide, then it really does not. And then the studies that followed were mostly done in Europe. So they're really very different in terms of racial makeup. And one of the biggest ones, called the Nelson trial, they actually had about 85% men. So women were a sub-analysis in the group. So, these trials are huge, and they gave us a lot of information about the mortality benefit, but they definitely didn't answer all of the questions that we had in terms of who would benefit from screening. I think that it is really hard to make sure that people get screening and know about it, and then also to adhere to the annual scan. A lot of it is very easy, like the scan is very quick, but it does require transportation to go get it. If there are language barriers in terms of understanding the eligibility or adherence, the time out of the day to go there. So there are a lot of nuances that I think would make adherence and follow-up a lot better.
I think what you said just reflects the challenges that exist in clinical trials and in general, and not just for lung cancer, the need for more diversity and more representation in clinical trials. I think there's a growing recognition of the need for that in the scientific community. I wonder whether psychological barriers can also impact the patient in terms of wanting to go through screening, where it's almost this notion of ignorance is bliss type thing. What are your thoughts on that?
I think you are totally right. I think it is really scary to think about having lung cancer and having a test that might find that and really just change your entire life. I think it's also hard because screening is based on smoking history. And we've known that smoking is a risk factor for lung cancer for a decade now. And so I think there is some stigma in terms of being a smoker, smoking despite knowing that there is that risk, and then potentially feeling like you caused this if you were smoking and have lung cancer. Now, a lot of people who smoke don't get lung cancer, and there are a lot of people who've never smoked who develop lung cancer. So I try to reduce that and really get people to feel more open to screening, but I can see that it is hard. It's a very scary prospect.
You alluded to this earlier when we were talking about LDCT, the false positive that can come up. And I think it's one of the things that it has been criticized for. Its high false positive rates, potential overdiagnosis. How do clinicians balance this concern when there are clear benefits for early detection?
Yeah, different clinicians will respond differently to this question. You're talking to one of the leads of the lung cancer screening program at Stanford. But if you look at the National Lung Screening Trial, they quote a really high false positive rate of almost 25%, which seems pretty ridiculous. When you look at the details, though, they count even a nodule that's 4 millimeters as a positive. And so these are nodules that are so small that we wouldn't recommend doing anything else based on that nodule alone. We would probably recommend another scan in a year, which is what is recommended anyway. So it would still count as a positive under the NLST definition, but wouldn't actually prompt any invasive evaluation at that point. So if you look at the false positive rate in NLST, for the first couple years, it was around just under 25%. And then for the third year, suddenly that false positive rate drops to 7%. And that's because if a nodule was followed and didn't grow, then it would be called positive initially and then switch to negatives. And so it's interesting. I think that some of the numbers of a high false positive rate don't really reflect the risk to patients, which is really the risk when we decide to do more evaluation. So invasive biopsies or testing that might actually have complications that affect.
I think what I'm hearing you say, and correct me if I'm wrong, what I'm hearing you say is do it anyway and basically do a repeat LDCT before maybe taking any invasive measures.
It depends on what is found. American College of Radiology actually came up with a full classification system of lung nodule just to make sure that things were standardized and we could talk about this false positive or false negative rate. They call it lung RAD. lung and then reporting and data system, lung rads, and it goes from essentially 0 to 4. And so each nodule that's found is classified as one of these lung rads. And for each lung rad, they have an expected percentage that are malignant, the expected prevalence within the population, and then the recommendations. For example, if you have a lung RADS 2, which is probably benign, they would say, get the scan in a year, which is what someone would do if they didn't find a nodule. And so a lot of those small nodules on NLST that were positive actually would just go along with this lung RADS classification, and nothing would actually be different for that person. Now, as you get higher in lung RADS, you get to ones that are very suspicious, and over 50% of those will be diagnosed as lung cancers. And those are the ones that you recommend. They call it tissue sampling or biopsy, and that can even involve surgery. And so I think that is when we have a much more detailed discussion with the patient about the options and the risks for these invasive procedures.
That's very helpful to clarify. I'm going to revise what I'm hearing from you at this point. Do it anyway, but your analysis of this quote unquote false positive is a little bit more nuanced. And there's additional classifications that you need to utilize to determine what to do with that.
The vast majority of people who have lung nodules found, many times what we do for those lung nodules, especially when they're really small, is just watch. When we find really small lung nodules, they're too small to biopsy or test in any way. And so the recommendation is just to follow them. So in that sense, if that counts as a false positive, that's something that won't necessarily harm someone. I think where we're worried about finding a false positive is when they undergo procedures like a bronchoscopy, a biopsy, again, even surgery. Sometimes I will remove a nodule that looks really suspicious with surgery because I'm so worried about it. And, we celebrate when it's nothing, but in that sense, that patient didn't need it. We just didn't know for sure. It is fair that we don't want to expand screening to everybody. 20-year-old, very unlikely to have lung cancer, and any nodule found is much more likely to be benign. So in that sense, screening someone who's clearly at extremely low risk doesn't make any sense because there'd be a lot of anxiety, potential other procedures or tests when most likely not lung cancer. The question is where to draw that line.
Yeah.
And I think that at least for heavy smokers, it's been answered. The NLST, despite these false positive rates, showed a mortality benefit. So that is an easy yes, go get screened. And the other question is other groups where we think they're at higher risk, but it's a little bit more unclear what that mortality benefit would be. That's where it's a little bit harder and we need more research.
Are there any emerging screening methods or technologies that could either enhance or complement some of the LDCTs and our current lung cancer screening practices?
I think there are a couple avenues. One is that the technology for CT scans keeps getting better. And so some of our radiologists, Henry Wu is one of them here at Stanford, is looking into photon counting CT scans and whether they could administer screening tests with even lower dose CT. So we called that ultra low dose CT scan. And then blood-based tests are a huge upcoming technology. We have one of our radiation oncologists, Max Dean here, who's been doing research in testing circulating tumor DNA in blood samples for many years. And I think those will be amazing when we could do, that will be even better than getting a CT scan if we could do that for lung cancer and potentially other cancers.
That really sounds exciting. The past few years, at least, AI is everything everyone's talking about. Has that been in the lung cancer screening space as well? Have we been talking about applications for AI in lung cancer screening?
Yes, for sure. There have been a couple different ways people have started looking at AI, but I think that there is a lot more to go in the future. Reading the CT scans, I think, is one big part. So finding lung nodules or following them over time, it's something that takes a lot of skill from our radiologists. And so trying to figure out if AI can be helpful in that would be great. And then I think also looking at risks for lung cancer in general would be another potential application. None of these are being used right now consistently. So I think, again, we have a lot more to learn about them, but I'm very excited about potential applications.
Looking forward, what do you envision as the future of lung cancer screening?
That is a really good question. I am hoping that one, we get people who we know are eligible now. We know there's a mortality benefit, that we find a way to reach them and get them screened. I think that's the most important thing. And then second, we know that other people will benefit. We're just not sure who exactly. And so I think that research will be really important to figure out how else we can save lives with screening. And then the last thing, which you already asked about, is other methods of screening. I think in the future, these blood-based tests, any test that will make it easier for people to get screened and diagnosed will be better and really help save lives.
This has been a wonderful conversation with so many key takeaways for clinicians, whether you're a primary care clinician or a lung cancer specialist. I so appreciate your time today.
Thank you so much, Dr. Adeluya. It's been great.
This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.